We are going live in 3, 2, 1. We are live now.
Good evening, ladies and gentlemen. Welcome to Pearls of Critical Care. Today is Friday, 17th of January. So let me begin by wishing each one of you a very happy and prosperous new year, as this is the first webinar that we are having this year. I was just telling Yatin sir and Dhruv sir that let's making it a very long-lasting one, and we have their blessings as well. Next slide, please. We all know who is our course directors, two stalwarts in the field of critical care, Dr. Yatin Mehta and Dr. Dhruva Chaudhary. We are extremely grateful to you, sir, for becoming our program director and leading the entire thing. A lot of young DM, DNB, and young residents will get enriched by this particular program. As we all know that this program continues, which is short and sweet, just over a period of 1 hour. So we intend to start it on time, and in a period of 1.5 hours, we would close it. And this is the way we would like to continue. Can you come down to the introduction slide, please? Ladies and gentlemen, the two stalwarts in the field of critical care is known to all of us. Just to mention few points about Yatin sir. Dr. Yatin Mehta is chairman at prestigious Medanta Institute of Critical Care, and he has pioneered and led the work in the field of critical care for many, many years. Many awards and accolades to Yatin sir's credit.
Manoj, just keep it short and
Sir.
Yeah?
Sir. So with such a great stalwart with us, I move on to Dhruva sir. I'll keep it short as well there as well.
Let's move ahead. Let Manju and all, please.
Right, sir. So we introduce the other participants, and may I request, program directors to introduce Dr. Manjunath and take it forward from there.
Well, it's a proud privilege to introduce Dr. Manjunath. He has been one of our students also as a colleague, and now he has grown in stature on its own. And he has been a member of Empower Task Group for Adult COVID Care Training Module, Government of India. He also was the National Committee Guidelines of Endobronchial Sonography and also procalcitonin. And his area of interest has been respiratory diseases, intensive care, ultrasonography, as also critical care. I think that's something where I pulled him in when he wanted to do his DM in pulmonary medicine. But I think that I told him, I said, if you want to do internal medicine, intervention pulmonology, critical care is essential, and trust me, one of the finest professionals I've seen in it, and also one of those people who has been a mentor to his juniors. That's what is the most astonishing at this young age, has got a head, which is very balanced. Manju, it's all yours. Please go ahead.
Thank you, sir. First of all, I thank the organizers, Pareshji, Dr. Manoj Kumar, for involving me. And I thank the course directors, Dr. Yatin Mehta sir and Dr. Dhruv sir, for giving me this opportunity to organize this particular episode. And today, I'll first go to the topic. Today, our topic will be connective tissue disorders, the critical complications. Basically, it's like connective tissue disorders in our ICUs. And we all know, just to summarize, connective tissue diseases encompass those entities like our SLEs, the Sjogren's, the systemic sclerosis, the idiopathic inflammatory myopathies, and the mixed connective tissue diseases, which can land up, the patients can land up into ICU with either the flare-up of the disease or the infection with sepsis or some other organ failure, which is sometimes becomes very tricky to differentiate and diagnose and manage properly. So many a times we are stuck in the patients who are critically ill and we don't know like what to do. So today we will take up two such cases where the management is challenging, the course is long, and the outcomes are unpredictable. So we will have two of our junior doctors presenting two cases from two different hospitals of Bangalore. And one will be Dr. Marina, who is our final year DRNB resident at Manipal Hospital, Whitefield. And she has been mentored by none other than Dr. Rajesh Shetty, again, one of the stalwarts in the critical care and well-known face, and he needs no introduction, I think. But just for the unversed, he is the director of the critical care medicine at Manipal Hospital, Whitefield, which is a well-known center for critical care facilities, which is running all sorts of courses, including super specialty courses, the IDCCM, and even for nursing. And he has been involved actively in all of the academic activities. And one of his courses, that is ultrasonography, has been a super hit, where it is pre-booked by almost 6 months. And he's also the chief of the medical services at the same facility. And the second case will be presented by Dr. Aditi Prakash, who is one of the most promising youngsters I have seen in the field of anesthesia and critical care. And she will take up the case of lupus. And she has been mentored by Dr. Nitya, who is the HOD and consultant of the critical care medicine at Medical Hospital, Bangalore. She has many chapters and publications, and she is one of the upcoming stars in the critical care for sure. And I think with this introduction, I will ask Dr. Marina to begin with her presentation. Dr. Marina, can you share your screen?
Yes, thank you, sir. Is my screen visible, sir? Good evening, all. I thank the course directors and organizers for the opportunity given to me. Today evening, I'll be presenting a case of a diagnosed case of polymyositis who presented to us with severe pneumonia. Like the confusion was, it was a diagnostic puzzle whether it was a community-acquired pneumonia or worsening of the interstitial lung disease. So the patient was Mr. X, 55-year-old male. He presented to us with a Apache score. Admission Apache score was 18, and he was in ICU for 16 days, and total duration of hospital stay was for 35 days. He presented to us with the chief complaints of fever, which was on and off for 1 month, and breathlessness for 1 week. The fever was present for almost a month, and which was relieved with medication. The fever was low grade in nature. Later, he developed breathlessness for almost a week prior to the admission. The breathlessness was MMRC grade 3 to 4 breathlessness. He was initially admitted to hospital when he was diagnosed as bilateral pneumonia with type 1 respiratory failure. And he had admitted for a duration of 5 days, during which he was treated with empirical antibiotics, piperacillin, tazobactam, azithromycin, and oseltamivir, and oxygen therapy. He was discharged home on oral antibiotics, domiciliary oxygen support, and steroids, oral prednisolone. But he was readmitted to the hospital on the same day of discharge with increased breathlessness. So in his past history, he had significant history of inflammatory myositis with interstitial lung disease, which was non-specific type, and he was on maintenance rituximab therapy. And the last cycle was given on 6th of March, that is almost like 2 weeks prior to the admission. Other than the polymyositis, he also had hypertension, diabetes mellitus, and a history of lower limb deep venous thrombosis, which was treated. So clinical examination revealed mild tachycardia, blood pressure was normal, and respiratory rate was around 28 on HFNC support. And he maintained a saturation of around 92% with settings of flow of 50 liters per minute and FiO2 of 70%. He was afebrile at the time. Systemic examination, respiratory system examination revealed bibasal crepitations. All the other system examinations was within normal limits. The initial laboratory parameters, all the parameters, the CBC, renal profile, electrolytes, liver function test were within normal limits. COVID-19 testing and flu panel was conducted, and it also came out as negative. The initial procal, that is during the previous admission, was 0.34, which was found to increase to 0.65 during admission. The BAL, which was done during the prior admission, the gene expert came negative, and the pneumonia biofire also was negative. The blood and BAL culture reports during the first admission also was no growth. So on admission to the hospital the second time, he was tachypneic and hypoxic and was initiated on NIV support. The antibiotic cover was started with piperacillin tazobactam, but within 24 hours, it was escalated to meropenem because of persistent hypoxia and worsening clinical picture. The trimethoprim and sulfamethoxazole was added to cover pneumocystis jirovecii in view of in view of the background of immunosuppression. The CT done during the second admission was suggestive of worsening consolidation compared to the first CT, which was done during the first admission. So the CT image being run here on the left hand side is the CT thorax, which was done during the first admission. So it is showing bilateral consolidation, which was more on the right side of the lung. Here on the right hand side is the second CT, which was repeated during the second admission. And this CT was suggestive of worsening consolidation and ground glass opacifications. So in view of this worsening consolidation and ground glass opacification, the antibiotic was escalated to meropenem. And steroid dose, which was initially hydrocortisone, was started initially, but then it was methylprednisolone was started. So even after escalating the antibiotic, the patient had worsening hypoxia, but all the cultures which was repeated came negative, and procalcitonin also was negative. Other features of respiratory distress like fluid overload, also there was no features of fluid overload. Then we thought in terms of worsening interstitial lung disease and a suspicion of rituximab-induced lung injury. So, in view of the same, we started him on pulse methylprednisolone to
Marina, I'll just interrupt you. I'll just interrupt
Yes,
you. 1 second.
Yes,
I'll just put a question to Dr. Rajesh Shetty. Sir, so we see a lot of these cases who are already diagnosed with the connective diseases.
Volume reduce them. Yeah, say that again, please. Are you able to hear me?
Am I clear,
May I
sir? now?
request everybody else to please mute mode
Okay.
because the sound is resonating.
Yes, yeah, it should be okay. Yeah, Dr. Manjunath, please tell me. How are you?
Yes, sir. Now it's clear. Good evening, sir.
Hi.
Sir, we see a lot of these cases who are already having a diagnosis of connective tissue diseases.
Mm.
And they land up with many a times with many complications, but I think most of the common complications are related to respiratory or kidney or sometimes even CNS.
Mm.
So whenever we come across a patient of connective tissue diseases with respiratory failure with lung shadows, there's always a challenge there to consider whether it is infective, whether it is a flare-up of the disease per se or the background ILD which is going on, or the third option is always the toxicity of the drugs, because many of the drugs which are used in this connective tissue diseases, be it rituximab, be it or MMF, or be it even methotrexate, they are known to cause these kind of lung lesions and respiratory failures, that is pneumonitis. So what should be our approach when a patient comes? Like, are there any clinical cues or at least lab cues which will help us in deciding the initial management when they land up into respiratory failure into our ICUs?
Good question, Dr. Manjunath. These cases, as you rightly explained, can be quite challenging, and this is a very good example. What we are discussing. Despite your best efforts, even in the end, you may not know what is the most likely cause for deterioration. So you have to go with your first principle. Basic, primarily from the ICU point of view, the most life-threatening causes you'll have to cover, and then and most common causes you'll have to cover. These patients are usually immunosuppressed, so the risk of secondary infection is quite high. And based on the clinical features of if they have fever, but sometimes these patients may not mount fever at all. If they have any respiratory symptoms like expectoration and chest X-ray signs of consolidation, I would cover with community acquired pneumonia first, unless they have had a previous hospital exposure where you have to consider higher antibiotic. And if there is no response to that, and also like in this patient, the procalcitonin was negative, and on the whole, it didn't look like it was an infective pathology. Then I would consider if the patient already had a known history of connected to this disease, whether it's an interstitial lung disease and whether that is worsening. And CT scan can be quite helpful in this situation to differentiate whether it is a lobar consolidation, which is a cause, or the worsening of the interstitial lung disease itself. And if they have had a previous CT of the lung, the comparison might be helpful. Having said that, sometimes it may be very difficult to, exclude one versus another. So after you have covered with appropriate antibiotic, I would start with increasing the immunosuppression. Many of these patients will have some immunosuppression, and guidelines again varies. What immunosuppression to use. Usually, you would start with the basic your steroids. Sometimes you may need methylprednisolone itself, and if the depending on the patient's clinical condition, you may have to pulse them with methylprednisolone as well, and then you take the response from there.
Okay, sir. Thank you, sir. Thank you. That was a nice explanation. Sir, Yatin, sir, am I audible, sir?
Yes, you are. Yeah.
Sir, now in these
Yes,
kind
I
of
would agree with Rajesh. See, you can be sure, but this is flare-up of the disease which the patient has, or it is a secondary sepsis. They're all immunocompromised. And this is one of the rare conditions where you will give steroids along with antibiotics and maybe cover for PCP as you rightly did so. If the patient is able, I think it is a good idea to do bronch, but not this patient. He was on initially HFNC and then BiPAP, so he was not going to tolerate a bronchoscopy. But whenever you get a chance, if the patient gets intubated, then early bronchoscopy would be indicated to a PCP or any secondary bugs which the patient has.
okay, sir. I'll ask Dr. Dhruv, sir. Any comments on the choice of the antibiotics, like which should be preferred, which should be avoided, or like which should be given more priority in these kind of cases where there is immunosuppression and lung lesions with respiratory failure, sir?
You see, Dr. Manju, what is extremely important is the type of pattern you see that decides to a large extent. You see, if your procalcitonin is negative and a person is immunosuppressed like rituximab, you have obviously with the knocking off of CD20, practically you are exposed to a number of infections, including tuberculosis, including your other bacterial infections. Most of the time, the standard thing is that any person comes, you try to cover with a beta-lactam inhibitor with atypical cover. Now, if your procalcitonin is negative, for me, very high up on the card, then starts going up. If I have some evidence to suggest bronchiolitis, which can be a problem sometimes in CTD ILDs, to consider viral infections also, which we must not forget, because the type of pattern of a diffuse involvement, starting with the patchy with some asymmetry, then it is going up. That can give us a lot of clues about those things. So if you have to start antibiotics, as I said, beta-lactam inhibitors. Along with it, you will use atypical cover. That will take care of most of the time. And for these patients, I will have a relatively low threshold. But because sometimes they may be sick, that it may not be possible. So sputum induction, if possible, one may try it. That is one part which can give you us a fair amount of an idea with multiplex RT-PCRs which are available to us. Not only film array, but other multiplex PCR systems are available. So that part I will see it. But starting from your question, my answer straightforward is, as I said, and I repeat it again, it will be a beta-lactam inhibitor. And in this, primarily will be one having an activity against Pseudomonas. So there you will start looking at it in terms of Piperacillin, ticagrelor is not out. Alternative to that will be carbapenem with atypical cover. This is how one shall be going up. But backdrop will be how frequent is the is the exposure to the hospital, how frequently they are going into the hospital. That is the one thing which we need to see. And secondly, in inflammatory polymyositis, myositis, acute or DIP becomes an extremely important component. And once after it is there, only then I will go for the rituximab. Rituximab leading to drug-induced lung injury is relatively uncommon vis-a-vis, like we are using pembro, we are using nivolumab, we have been using other immune check inhibitors, etc. in lung cancers, or for even for the immunotherapy. Rituximab, we have seen secondary infection, but rituximab-induced lung injury is relatively uncommon. Therefore, if there is a response to both IVIG plus steroids, I would like to keep a possibility in this particular case of a basically diffuse interstitial pneumonia happening as a part and parcel of the primary disease process.
Sir, any word on empirical cotrimoxazole, and even should we consider CMV when the ProCal is negative and we have this bilateral diffuse kind of things?
You see, CMV will be there again. You need to go and discuss with the radiologist, because different viruses have different presentations. Suppose if somebody has an RSV or has a parainfluenza viruses or even a human metapneumovirus, you will find an evidence of bronchiolitis. Similarly, in the patients who have got your influenza, you will have more perihilar central lesions, and then you will tend to see going up. There will be a diffuse involvement which is there, and in patients of COVID, we saw all sort of pattern. Now you're talking specifically of a CMV. CMV, again, we need to, radiology gives you a lot of clue in terms of the septum becoming thickening, and there's a diffuse alveolar thing. CMV can never be ruled out in these cases. But again, the answer suggestion will be CT radiology, the chest CTA, and then subsequently you need to do a fiber optic bronchoscopy to find out in these patients the CMV there. And ideal would be to do a transbronchial lung biopsy where you can see them there, but that sometimes can be very tricky. And or alternative to that is that in the blood you may do a CMV PCR to find it. Earlier we used to do PPV25, but that was more in the urine. You can go for the blood CMV, but that will be all part and parcel of work of an immunosuppressed case.
So are we justified in starting cotrimoxazole, sir, empirically? Like we didn't have proof of any PCP, like microbiological proof at least. You
see, again, the answer, Manju, is the same, sputum reduction and all. Obviously, when you are trying to do it a person who is immunosuppressed, that's a Pneumocystis jirovecii. If you start looking at it, immune suppressions most of the time, whether it's corticoids for 20 milligram plus of and all, it's a part and parcel of practice of it. But early phase, when diffuse glandulosis is there, it is difficult. If I get a cyst around it, I become more definitive. It's, I think, something of that. They're trying to use all the guns blazing so that they cover it up in the beginning and then gradually tapering it off.
Okay, thank you, sir. Dr. Yatish, are you
Yes.
offline? Am I available?
Yeah.
Dr. Yatish, sir, sorry, I forgot to introduce him. Dr. Yatish?
Yeah, I am available. I'm here.
Yeah, sir. Sorry, I just skipped that. Dr. Yatish is our rheumatologist, and he's one of the big names in rheumatology in our Bangalore. Currently is working for Aster Hospital, Whitefield, and he has been the backbone of all our rheumatological cases across the Whitefield patients, and he takes care of his patients so well that patients are often like his fans. So thank you for joining us, Dr. Yatish. In these kind of cases, when you have given rituximab already, just like 1 month ago, and you know that his disease activity is probably well controlled because you have already given rituximab, and he comes up with these kind of this one, how comfortable are you in pulsing him with steroids? And what should be the optimal dose? And do you consider any other immunosuppression, thinking that it may be a flare-up?
Yeah. See, the situation, this particular case, I mean, we need to go to, again, the basics of what is the primary diagnosis. See, most of the time, the diseases, what we deal, they are the kings. I mean, we always say that disease determines the course of the overall illness. I mean, In this case, let's say if you see the prognosis, he is a male patient, 55-year-old male with a myositis, polymyositis picture on rituximab, not doing very well. The fact that he has gone to rituximab itself says that he is having a little aggressive form of myositis. And specifically this entity, that SRP positive, this one myositis entity, we call it as necrotizing myositis. This itself has a very bad prognosis. If you just go to the background, the basic disease pathology, it's one of the aggressive form of myositis, and it is known to have a bad prognosis. In fact, the mortality is high. The extra muscular involvement, in the form of usually myocarditis or overall bad prognosis, very high. I mean, that is how the background is. So here we can say that disease per se has a very bad course. That's what we are actually seeing. And with rituximab, of course, rituximab is a very potent molecule. Most of the rheumatological diseases do well, but certain entities, what we are discussing today, myositis is something which is very difficult, right from the diagnosis to manage, to know the spectrum of the disease. Everything is very difficult. I mean, with current myositis profile, antibody profile, we can just say the prognosis. So this entity as such has a very bad prognosis. So I would say rituximab, yes, we have given a good amount of steroids, but this being a very bad prognosis still can be a part of disease activity. As Dr. Rajesh Shetty and Dr. other senior colleagues also told us, with this background, with procalcitonin being negative and cultures, everything being negative, yes, we still have to consider as one of the possibilities. Of course, no one can clearly say whether it's an infection versus disease activity. That's where most of us will land up in a situation in ICU where we will be always, there are pros and cons. I mean, there are more favoring infection, more factors favoring like disease activity. That's where we have to have all sit together, include the radiologists, talk to them, what is the pathology, I mean, what your suggestion, and then come to some meaningful conclusion. And most of us will treat both together. I mean, we'll be covering up majority of the infections and also treat the disease activity by steroids. And as also the topic of rituximab induced lung injury also came in. I mean, that's, even I feel that rituximab induced lung injury is probably we have been using rituximab since quite long time, and it's been quite effective. But this entity were not seen practically. But yeah, it does exist in like literature. But considering all these things, yes, all the options should be kept open at this point. I mean, as we move forward, probably we'll get more highlights.
So, what is your opinion on pulsing these patients with steroids, and what should be the dose? Like when we say that word pulse, it's like empirical. Whether I go for 250 mgs of methylpred, 500s, and we can even go up to 1 gram, we can see that. So,
Correct.
what should be the ideal dose, and how do we choose the dose?
Yeah. See, steroid is one drug where you will never find a like kind of randomized control study in any of the diseases. It depends on current clinical situation, and I mean, most of us in rheumatology practice, we are going down with the steroid doses. We are not very happy giving very high doses, because what has been shown in recent studies is even low dose steroids work well equivalent to very high doses. So most of us are happy giving 250 milligram to like 500 milligram pulses in such situation where we are thinking that this is an organ threatening disease. Like currently we are seeing a fact that, okay, we are having an organ threatening disease or a life threatening disease. Probably 500 milligram is what, once we have covered up the infection, we would be happy to give. If the disease is even milder, let's say in an OPD basis, we are treating someone simple kind of myositis, or even for arthritis flare-ups or simple lupus flare-ups, 250 also we do use pulses for 3 to 5 days kind of thing.
Okay, so that I think clears the air about the steroids per se. Dr. Nitya, I have a question for you. So being intensivist, we get these patients into ICU. They are in respiratory failure. They are requiring very high amount of oxygen. And he's tachypneic and he's immunocompromised. Now, what would be your initial choice? Will you go for HFOT, or do you think, because it is a relatively newer entity compared to our non-invasive ventilation, the NIVs. So how do we choose, and what should be preferred here?
Yeah, so I think this we have to take this on a patient-to-patient basis. So usually, I think previously we've been using NIV, like when the patient comes in respiratory failure, especially immunocompromised, we wouldn't want to rush and intubate them. We would like to give them a non-invasive ventilation initially. But HFNC also, as nowadays we are seeing that patients are more compliant with HFNC, and initially if the patient is not too dyspneic, we can give a fair trial of HFNC. If they settle with that, they're much more comfortable, especially where they can take orally, talk, so they're more comfortable with that. So definitely I feel we can try HFNC, and if they're not settling down, then sometimes NIV provides slightly higher support where we can go ahead and put them on NIV also. And intubation will be because these patients are immunocompromised, we wouldn't want to rush and put them on ventilator immediately. Only if these non-invasive techniques fail, then we would like to go and put them on ventilator.
So NIV or HFOT?
I think HFNC as of now, yes. Initially, I would like
Yeah,
to.
yeah.
But
See,
yeah,
multiple.
Yes, sir. Please,
yes.
sir.
See, multiple studies, hypercapnic or type 2 respiratory failure, NIV is superior. But otherwise, for hypoxemic, I think they are both quite equivalent. And HFNC definitely is more comfortable for the patient.
Yes, sir. Thank you for that final word, sir. I think that clears the doubt. And now I request Dr. Marina to continue with the
Dr. Mehta has said it. You see, when you start looking at, there's a number of studies which are showing it, which sort of two things you need to be there. You need to calculate the work of breathing, or you have to see whether the work of breathing is more or not. If you find that work of breathing clinically is more, then it is the CPAP which is preferred, or you may use at that point of time sometimes the BiPAP. But CPAP is somewhere that is preferred, and that's why number of studies are showing it up, which is equivalent to HFNC, but probably it should be fine. Secondly, which is very important, is that the choice of interface is very important for the NIV. If I have to do for the acute lung injury, then if I want to use NIV, if there is no work of breathing we will measure looking at it accessory muscles A and intercostal indwelling, which is part of that. Or in blood gas, if I'm finding consistently CO2 wash off is there and it is less than 35, these two things combined together clinically give you an idea about it. And then secondly, if I have to use, I will like to use helmet mask, which you have used quite often with us in Rohtak also. Their equivalence is coming up between HFNC and all. But what Dr. Mehta said, humidification it's far more comfortable with high flow nasal cannulas. The only problem which starts coming up is the consumption of oxygen in the pandemic situation. But otherwise, choice depends upon the expertise of the team. But in acute lung injury, definitely, which is leading on to acute hypoxemic respiratory failure, mild to moderate, it is good enough. But if work of breathing is, you go to CPAP, and there is some evidence of normalization, because that's how you look at and calculate extreme work of breathing. That's very, very important for us. And if you want to use BiPAP, you can very well use it. But then preferably you should use helmet as an interface than anything else.
Thank you, sir. Now I request Dr. Marina to please continue with the presentation.
So the patient was started on pulse, pedal prednisolone, and intravenous immunoglobulin therapy. And after starting the pulse steroids and IVIG, there was improvement in hypoxia by day 5. A follow-up CT, which was done later, was suggestive of improving consolidation and ground glass opacification. Here is the CT.
I'll just interrupt you here, please. 1 second. Now,
Yes.
This is a new topic. Now, Dr. Yatish, any take on this IVIG? Why was it chosen, and what are the advantages along with methylpred? Because I think this is relatively a tough decision when to start IVIG and when to go ahead with. Maybe we have many more options like cyclophosphamide. We have. So what is the logic behind this IVIG in this particular case, please?
Yeah. See, so whenever, again, the primary disease is one priority. Whenever we are dealing with myositis, IVIG has a proven role. I mean, it is recommended proven therapy for a disease, aggressive disease like this kind of spectrum. And also, whenever we are in a doubt of whether, let's say, infection versus disease activity, since IVIG helps for both kind of situations where, and it can be safely given even if the infection prevailing, and we are still in a negotiating time for buying time kind of situation. See, here we are kind of losing the patient. I mean, the patient seems to be worsening either because of infection or like disease activity. Such situation, IVIG is one of the best bet, especially in an ICU setting. Most of the autoimmune diseases where we have this confusion about an aggressive disease versus kind of infection, IVIG is our rescue, because it will give at least 5 to 6 days of time frame where we can cover up the patient with good antibiotics. We can get the cultures done, we can get the bronch, we can get some biopsies done, at least with some conclusive like, let's say, disease evidence, or the other way, infection evidence, we can treat the infection. So IVIG is a best modality here. And in this case also, we can see that there was some good improvement with this combination, steroids plus IVIG. And usually when we speak about other indications, let's say rituximab in an acute situation, it takes 2 to 3 weeks more than that to work. Obviously, we'll not be aiming that as a primary modality for now. IVIG works faster, can be given during an infection setting. That's why IVIG is the best bet here.
Thank you. Thank you for that information, Dr. Yatish. Yeah,
Yeah,
Dr.
just
Marina,
wanted
please.
to,
Yes.
Dr. Manjunath, I wanted an opinion of Dr. Dhruv and Dr. Yatin Mehta as well. I feel IVIG may not have been required, and there are no studies to show that IVIG is helpful in this situation. I think most of the studies or even recommendation, if you look at, it talks about only steroids, increasing doses of steroids, including pulse steroids, and probably that would have been enough in this situation, I feel. But obviously, at that time, we were in a desperate situation. I was the treating consultant for this patient as well. And despite our initial treatment, the CT scan was showing that the disease was progressing, and we thought we have to do it. Now, what is the opinion of Dr. Dhruv? Would you have used IVIG? I think now, looking back, I feel probably pulse methylprednisolone what worked for this patient. IVIG was not required. What you would have done?
Over the years, Dr. Shetty, I have become a little more comfortable with IVIG because one of the major reasons because of which immune modulation we have not been doing it is primarily the cost. That is part one, because it's quite expensive, 2.4 or 2.5 lakhs. And obviously, when we look at the outcomes in terms of it, today there is a term which we use it, not only the clinical efficacy, but also we look at it in terms of monetary efficacy also. That's what the NICE does it in UK, and that's how we have now started evaluating in terms of in an Indian context. So if that is there, but purely from the technology or purely from the scientific perspective, you see what options do you have in the acute immune setting. One is your monoclonal antibody. Already you have knocked off CD20. Now what are you left with after that? Steroids, obviously you will try to use it to modify the T cell response, and also the other component, because if you look at the activity of the IVIG, it is a multimodality activity, one. Therefore, I am not surprised. The only thing which you have put it up, in hindsight, we can always be wiser. But in autoimmune disorders which are recalcitrant, not responding, this is something besides rituximab, which has come up as a magic drug. For a number of these things, we are trying to use IVIGs, and especially one condition I have not discussed in this thing, which is not otherwise fitting into it. We must not ever forget the macrophage activation syndromes. So under those conditions, these are the same drugs which are combination being used. Now, it depends upon the team, and it also depends upon the X. Now, whether it was steroids also lead to significant immune suppression, whatever is left. At least with the intravenous immunoglobulin, you are doing much more immunomodulation, and you are not worried as far as the infective component is concerned. The only thing you need to take care of is that kidneys may not knock off if they are containing glycerol as in it. If that is not there, fair enough. Means if what you have done it today, probably I would have done the same. Probably I would have been a little lesser with the steroids. I would have gone 250 to 500. That would have been my difference.
Thank you, Dr. Dhruv. At what point would you consider IVIG? You would give methylprednisolone. How long would you wait before deciding?
We give methylprednisolone. Idea of methylprednisolone is to have a rapid onset of actions. Already a person is in a corticoid, you give steroid. Most of the time in 48 to 72 hours, response starts coming up, not in terms of improvement of oxygen, at least worsening stops. But if I find out that there is a continuous downhill stroke, I will not hesitate after 48 to after at least 2 to 3 days of methylprednisolone pulse, if it is not responding. Because over a period of time from 1 gram 3 times a day, 3 days, I have reduced myself there so as to see, assess, and then look at it, because once it has been shot, it's been given, nothing can be done. Cutting it short, what I'm simply saying is, if response is not coming up, means the halt of the disease doesn't stop in 48 to 72 hours, upper limit is 72 hours, some idea starts coming up. If it is not there, that is the time I may consider it IVIG, or upfront. If I'm reasonably certain that it is an autoimmune burst thing which is there, I could use that also upstream, depending upon it, the patient's pocket, because they have paying it. But I will not hesitate even upfront using it.
Yes, yes. I think that's what we did here as well. We waited for 48 to 72 hours, and there was no clinical improvement. Then I know it was a desperate situation. We didn't want the patient to deteriorate any further, and IVIG is given.
I think it's fair enough.
Thank
These
you.
are clinical decisions, and we have to respect that, because there is no definitive guideline.
Yes.
The only question you escalate as per the algorithm. If person is not responding, patient will not improve suddenly, but halt of the continuous progression must happen. That is the key.
Yes, it's a practicality thing, I think, rather than going on the recommendations. You have to decide on the floor, and looks like the practice probably is the same, is what you are also saying. You would have done the same thing. Thank you.
Science is there. The only thing is the art of medicine needs to be practiced.
Yatin sir's take on this, sir, IVIG.
No, I would agree with Dr. Dhruv completely. I will give 500 of methylprednisolone, and in 2 days' time, if the patient is not getting better, I would give IVIG, because this patient goes on a ventilator, then I think maybe we will probably lose the battle.
Thank you, sir. That clears the doubt, I think.
Yeah, please.
Dr. Marina, please continue.
So then gradually the oxygenation of the patient improved over the next 5 to 7 days. HFNC support was tapered gradually, and steroid therapy was continued with hydrocortisone after the pulse methylprednisolone. Later, his sputum culture came positive for aspergillus, and he was started on voriconazole for the same. By day 16 of ICU admission, he was stable on minimal support of HFNC, and he was shifted to ward. Pulmonary rehabilitation was continued in the ward. In ward, he had fever spikes. The culture urine came positive for E. coli, which was treated as per the culture sensitivity report. Gradually, he was weaned from HFNC to face mask and then to nasal prongs. And patient was discharged home on day 35 of hospital admission with domiciliary oxygen support. So this is a graph of all the investigations of the patient. So other than the type 1 respiratory failure, all the investigations of the patient was within normal limits. And these are the culture reports of the patient. So to discuss in brief, the interstitial lung diseases are a collection of heterogeneous collection of distinctive lung disorders. So this involves a series of inflammation and fibrosis. So the ILDs has been classified as idiopathic, autoimmune, hypersensitivity pneumonitis, or other ILDs which are associated with drugs or other occupational exposures. So the main management in the ILD consists of pulmonary rehabilitation, supplemental oxygen, corticosteroids, and immunosuppressant therapy, including MMF and rituximab. So here the flowchart is the treatment guideline for interstitial lung diseases associated with the polymyositis. So coming to rituximab-induced lung injury, this is a very rare entity. The incidence has been documented as 0.03 to 0.04%. There has been only very few case reports of rituximab-induced lung injury. So the pathogenesis involves the rapid lymphocyte lysis and complement activation and tumor necrosis factor alpha release, which will worsen the lung injury. This will lead to alveolitis, fibrosis, alveolar hemorrhage, and pleural effusion and consolidation. So the onset is usually within weeks of rituximab therapy, and it happens usually after the 4th or 5th cycle of rituximab therapy. The presentation will be with fever, cough, and exertional dyspnea. Treatment will be discontinuation of rituximab, supportive treatment, and high-dose corticosteroids. In refractory cases, IVIG can be used. Thank you all for your time.
Thank you, Dr. Marina, for that nice presentation. I think one more drug we need to discuss about whenever we discuss about connective tissue disorders will be cyclophosphamide. I think I'll take up this question to Dr. Yatish. Dr. Yatish, any take of when we do prefer cyclophosphamide in acute conditions? I mean, acute conditions in CTDs.
Yeah, I mean, cyclophosphamide in a ICU setting is difficult when you are almost certain that there is no infection. Because cyclophosphamide, we are obviously it's a very potent drug, and so in conditions, let's say if you ask in a critical case situation like something like a vasculitic condition, which is let's say typical example being a pulmonary renal syndrome with ANCA vasculitis or small vessel vasculitis. That is where upfront we would say that yes, I mean if the presentation is very clear, like pulmonary hemorrhage with glomerulonephritis on biopsy, then there is no waiting. So start with cyclophosphamide along with pulse steroids. But situations like this where we are kind of a lot of discussions today, also we discussed what is the best modality. There is nothing like best modality because the diagnosis are always in doubt, like we are about like conflicted between the infection part and the disease activity. In this situation probably cyclophosphamide will not be using, but the disease has to be very clear what we are treating, that where we can give cyclophosphamide because there is no reversal. It's a very potent molecule, that's why.
So we have to have a high threshold to use cyclophosphamide. That's what you want to say.
Correct. Yeah.
Okay, sir. So
Drew, sir, I hope my colleague from rheumatology will agree, has been an old man's IVIG to begin with. When we had nothing, we were using it up. And that's why upfront its role has gone, except in patients of vasculitis, where we want induction, even rituximab is taking over there, as far as the induction of remission is concerned in the earlier phase. And then obviously you're continuing with the maintenance therapy. I hope Dr. Yatish will agree. Because if you look at the old studies, all vasculitis thing was endoxafen and steroids, and then long-term endoxafen. One of the major challenges from the pediatrics, which we have known with endoxafen over a period of time, has been the secondary malignancies, solid malignancies after 2 to 3 decades. That has been the challenge. But nevertheless, the thing which revolutionized the treatment of vasculitis and remission has been, as I agree with him, in this patient, whether it was a rituximab or whether it was a disease, I think that still needs to be. I'm not very certain whether it is all rituximab induced which has happened, because once if it is a rituximab, looking at the diagnostic conditions which Dr. Yatish did talk about, then you have to look for an alternate medications beyond it. And secondly, rituximab will continue to have an anti-CD20 low levels up to next total of 4 to 5 months. So in this light, Dr. Yatish, what will be your approach? Because obviously this is not an intensive care case now, then it becomes a internal medicine rheumatology. But rheumatologist and rheumatologist, because that will, if rituximab induced lung disease, and probably shivering into whether to give him rituximab again or not. But if it is a acute pneumonia because of myositis, which is not uncommon, then probably I'm comfortable with that.
Yes, sir. I mean, as you rightly told, I mean, rituximab induced lung injury is very rare, and no one can 100% say that it is the drug which has caused. So whenever we have a conclusive evidence and whenever we have a other option to treat in future, probably we'll keep it aside. Otherwise, if patient has been better on rituximab so well, and this we consider as more like a disease-related kind of lung injury, then going forward, probably we are more comfortable to go ahead with rituximab.
Okay. Thank you, sir. Sir, Rajesh sir, one final question. So now that you know you are wiser in this case, was it infection or was it a flare-up?
I feel it was a flare-up only, and it probably responded to the pulse methylprednisolone. IVIG probably was not needed, but given the circumstances, we had to give. But I don't think there is any right or wrong answer. There is no way to prove or disprove it. But my gut feeling is that it was a worsening of the ILD itself, and possibly not rituximab, induced acute lung injury. And from whatever paper I have seen, they usually don't seem to have that severe. If it was rituximab, as Dr. Yatish already said, you hardly see, patients with acute lung injury related to rituximab. And even if you see, as per the literature, it looks like it causes a mild disease. Here, I feel it was a worsening of the interstitial lung disease itself.
Okay, sir, just to
Now,
continue.
let me be the odd man out here. You are not sure what was the etiology. Okay. The question came up, a few slides were shown on query rituximab-induced lung injury. So you are not sure. I agree that rituximab-induced lung injury or this sort of a thing is not very common. But since the doubt has come up and you are not sure what it is, what were people using before rituximab? There were drugs available, which Dr. Dhruv has already expanded. So I would hesitate to use rituximab again if I'm not sure that it was rituximab or not.
And the problem is there is no foolproof method to prove a rituximab-induced lung
So
injury.
why not use
Matthew,
conventional drugs like
let's-
cyclophosphamide? That's what I'm saying.
I agree with Dr. Mehta. I think we are all saying the same thing. Let's move to the next case so that we leave it to other day to discuss with the dermatologist and pulmonologist, right?
Sure.
So let's move to the second case and stay to the critical care and let I'm very certain it's an old case, so you must have had. Yeah. Excellent.
That was a nice case and a very good discussion. I think we are clear and still not very clear with many intricacies of the management of these kind of cases. And now I think I will request Dr. Aditi Prakash to take up the second case. Dr. Aditi, please. Dr. Aditi, you need to unmute yourself.
Am I audible now, sir?
Yeah, now you are audible. Please go ahead.
Okay, so good evening to all. The case I'm going to discuss today is that of a mixed connective tissue disorder, which overlapping SLE, which complicated because of diffuse alveolar hemorrhage. So the aim here is to highlight the critical diagnostic and therapeutic challenges which we often encounter in these cases. Slides are not moving. Just a second, sir.
Yeah, please, no issues.
So our case was a 47-year-old male patient who's a known case of hypertension, positive for rheumatoid arthritis factor since childhood, and was recently diagnosed with SLE. He presented to us with complaints of breathlessness on exertion for 2 to 3 days with vague body pains and lower limb joint pains. He also had history of restlessness and delusions for the past 3 days prior to this admission. Actually, this patient presented to us 2 or 3 times over a course of 2 months last year. So the first 2 times he was admitted in the ward, only the third time he came to ICU to us. So in May 24, the patient was apparently all right when he first developed multiple oral aphthous painful ulcers with the history of significant weight loss and hair loss. And he then also developed worsening occipital headache with accelerated hypertension and was commenced on prazosin and cilindipine in his first visit. The next time he was admitted in June last year, he presented with anemia, and then he was transfused with 2 units of blood. And on discharge, this was the lab picture that it looked like. So the hemoglobin was corrected to 11 point. TLC were normal, platelet was over 1 lakh, and creat was 1.21. He was discharged with prednisolone, leflunomide, methotrexate, chlorthalidone, and amlodipine for treatment. After this discharge, the next time he came, he had recurrence of aphthous ulcers with rash and generalized body pains, and there was swelling with lower limb pains. Then he was reevaluated and was diagnosed to have SLE with the anti-nuclear antibody titers positive with the fine and coarse nuclear speckled pattern. He was also positive for anti-ssDNA antibody, as was anti-U1 RNP antibody, which was positive. C ANCA, P ANCA were negative, and HLA-B27 was also tested for and was negative. Viral markers were also negative for this case. So as we know, systemic lupus erythematosus, it's a systemic autoimmune disease with multi-system involvement and is associated with significant morbidity and mortality. There can be genetic, immunological, endocrine, or environmental factors which can play a role in the E2 pathogenesis. Although it predominantly affects the women of childbearing age with a female to male ratio as biased as 9:1, but when it does affect the male gender, it tends to be more severe. And they also have to have more skin manifestations. Cytopenias are more common, renal disease, serositis, neurological, cardiovascular disease, hypertension, vasculitis. All these are more common in the male population as compared to women. So this is the SLIC criteria, as we know. So our patient had oral and nasal ulcers. He had non-scarring alopecia and arthritis. Later on, he also had renal and neurological involvement, and cytopenias were there. And he was ANA positive. So that's why he was labeled with SLE. So one thing that we need to emphasize here is that such progression of a patient from vague symptoms to confirmed diagnosis of SLE underscores the complexity of autoimmune presentations. And this particular case was more complex for us because he also had overlapping clinical features of multiple connective tissues. The patient was positive for RA factors since childhood. Later on, he also had Raynaud and had muscle weakness. So that completes the clinical triad for mixed connective tissue disorder. And like I mentioned earlier, he was positive for the ribosomal nucleoprotein antibody, which is also a hallmark of MCTD. And he was negative for dsDNA. So with presence of this clinical picture with anti-U1 RNP antibody and with negative of any antibody specific to a disease, which is dsDNA for this case for SLE, we could label him as having mixed connective tissue disorder. So after this diagnosis, he was discharged with prednisolone 30 milligram, mycophenolate, hydroxychloroquine, gabapentin, naproxen, and leflunomide. On the second admission, that is 2 weeks after this presentation, the patient developed breathlessness on exertion, which was insidious in onset. It was gradually progressive. There were no particular aggravating or relieving factors. He had complaints of generalized body pain and lower limb pains. He also had complaints of nausea and history of 2 to 3 episodes of loose stool, which was not blood tinged. There was no history of cough, fever, chest pain, or palpitations, no history of abdominal pain or bladder disturbances. On examination, patient looked emaciated and restless. He was afebrile, pulse was 88. And by the time he came to us, he was already on minimal NORAD support and was maintaining BP. Saturation was still maintaining on room air. Though he was mildly tachypnic, it was acidotic breathing. Pallor was there. There was no icterus, cyanosis, clubbing, lymphadenopathy, or edema. No visible joint deformities were there. He had non-blanching erythematous rashes over the upper extremities. Chest was clear on auscultation. Parabdomen was soft and non-tender. And CNS was grossly normal on examination. He was conscious-oriented and GCS was full. This is the investigation panel, which is short. So he has now presented with pancytopenia. From the previous admission 2 weeks ago, when we discharged him with a hemoglobin level of 11, it has now come down to 4.1. Platelets from over 1 lakh, it's gone down to 17,000, and TLC has also gone down. Creats are now raised to 2.8. There is azotemia and hyponatremia. There was mild transaminitis, and urine routine showed 8 to 10 pus cells on scopy. ABG showed metabolic acidosis, and CRP was also raised. So now the issues which we had with this patient was he has pancytopenia. He's presented with acute kidney injury. There is mild liver dysfunction, and he has altered sensorium. So our differentials at this point was either a SLE flare, which could also be secondary to sepsis. There could be methotrexate toxicity because the patient was on methotrexate treatment for quite some time, and he was also taking naproxen, which can add to the methotrexate toxicity. Or it could be MAHA, it could be TTP also. So then we did our second line of investigation on this line. At this point, the LDH was...
Dr. Aditi, may I interrupt you here, please?
Yes, sir. Please, sir. Please, sir.
Can you go back to the previous slide?
Yes, sir.
Yeah. You see, and if you go to the previous swing hemoglobin of 4, you have written pancytopenia, but you have to write here, look at it. You are having a pancytopenia, But if you look at it, it's a severe marrow suppression which is happening. And in this case, why there is a drop of the hemoglobin from 10 to 4, and person is having a severe, obviously, multiple other factors which have started coming up. We need to take into account. Look at the CRP which was there. Obviously, patient is having an acute disease flare. There is no confusion at all in this matter. I hope Dr. Yatish will agree with me. And obviously, you are trying to build up a story here. If that is AST is more, ALT is more than, therefore, I'm not finding any evidence of hemolysis also, because there can be spherocytes in the peripheral smears, which unfortunately we have not written anywhere about it. So there is no evidence of autoimmune hemolytic anemia, at least on this picture. What we are seeing is a kidney showing issues, and along with it, you are finding more than 2 organ system, and the consequence of this with the severe signs of inflammation. If I read it, there is a marked acidosis with elevated lactate and hyponatremia, which is there, and that can very well explain to us the values of if there is an autosensory. Next, please. Yeah.
Okay, so these were the second line of investigation. LDH was elevated at this point. Haptoglobin was low. The absolute retic counts had increased, and the peripheral smear also showed cystocytes, 5 to 6%. The cutoff for TTP is 2 or more than 2% of cystocytes on peripheral smear. And he had low levels of complement C3 and C4. So at this point, we could not rule out TTP, because he had by this time renal LCNS involvement. He had thrombocytopenia, there were cystocytes. So we sent for ADAM-TS activity, which was borderline normal, and the antibodies as such were negative.
But you see, again, very important thing is when you are looking at a TTP in terms of differential diagnosis, one of the important thing obviously is the microangiopathic picture, along with the involvement of a kidney as well as the CNS. But I would have expected then the sodium would have been normal. Now, in this case, to me, a significant amount reduction in sensorium seems to be because of low sodium. So we need to take in account. But yes, TTP, as a differential, you will do it, and you admits activity is normal. So very unlikely that this person is going to. So everything what you're seeing is an active condition. And you look at there's a low values of C4, which is coming up. And my request to all of you is that whenever you write, please always write in normal values in the bracket, because sometimes measurements on the different tests and kits, it could be different. So it is looking like a disease activity.
Yes, so that's what we thought at this point. So these were the cystocytes which we saw on the peripheral smear. Maybe here you can see it better. This is the lab.
Where you can see cystocytes.
Sorry, sir?
Go back.
What are the other conditions where you can see this microangiopathic picture or a cystocytes?
Sir, pertaining to this case, it could have been an antiphospholipid syndrome also. But actually, we did consider that differential, but because of monetary constraints, we could not do APLA test.
Very cystocytes are there. You need to see there's something gone. You look at the drug history. Which drugs can cause a picture like the thrombotic pictures, especially if persons are having calcineurin inhibitors. Dr. Yatish will correct me if I'm wrong, please. And also, it is equally important that you need to look at hemolytic uremic syndrome. You need to look at it, a DIC, and all those things will start coming up into picture right at this point of time.
Yeah,
so you need
was always normal, sir. We did not suspect or.
Pardon?
The coagulation profile was normal, so DIC was.
DIC now, I agree. But when we ask about the differential diagnosis of schistocyte, it starts coming up. Similarly, for the Apple syndrome, you need to tell me both sides, the arterial or the venous thrombosis, or there is an abortion. You see, you can have either arterial thrombosis, you can have a venous thrombosis, or your combinations. So we need to look at from the clinical perspective. Agreed, tests can be done, and that can give us a lot of ideas. Please go ahead.
I'll also interrupt you, Dr. Aditi. Please, we'll take some inputs from the other experts. First, I'll go to Dr. Yatish. Now, she was talking about this evolution of these connective tissue disorders from one entity to other entity, confusing us a lot. does it really matter for you when the patient is presenting to a ICU? Dr. Yatish, please.
Yeah, see, evolution of disease, I think most of the senior colleagues here agree that disease in rheumatological conditions evolve over a period of time. I mean, every few years or every 5 years, 10 years, we see a disease being treated like a rheumatoid arthritis. Later on, comes up with a diagnosis of, let's say, SLE or systemic sclerosis or MCTD. Later on, we do see a myositis kind of picture. When disease evolution is definitely there, most of us are not very keen on labeling the diagnosis. It's more important to treat what are the disease spectrums. Let's say the same patient who had arthritis for a long term, so probably he was receiving methotrexate and low dose steroids or hydroxychloroquine for that part. I mean, it was arthritis which was predominant. Later on, what we are seeing currently, as Dr. Dhruv was rightly pointing out, so there are clear signals that the disease has suddenly come back with a very vengeance kind of thing. It's very active now. I mean, we don't know what is the trigger. A trigger can be an infection. We don't know exactly. But yes, the disease, labeling a disease per se, helps us on a prognosticating situation. But situations like this, we'll just treat it as per the manifestation.
Whether I call it lupus, whether I call it MCTD, doesn't make much difference to my management strategy. That's what you want to say.
No, it makes a huge difference for long term, but situations like this, I mean, in a critical case situation where we will not argue about what is the diagnosis here. We will be treating, because we know that it's an autoimmune disease which has come up with a very aggressive form. So we'll be treating accordingly, because these antibodies, these disease processors are very, I mean, like confusing. So one day we treat the same. I mean, it has happened for me also. My many senior rheumatologists, like my own teacher, let's say, we have seen patients like Dr. VR Joshi in Mumbai. He used to treat it as rheumatoid arthritis. Then Dr. Balkrishnan, who happens to be my kind of guide and main teacher, so he has treated like a SLE. And then when we were treating the same patient, they come up with a myositis and ILD kind of picture. I mean, finally, patient died with myositis and ILD. I mean, that's how the course, it spans across the decades. I mean, it's very difficult to label and stick to that.
So in critical care settings, we need not crack our head over what is the label, but yeah, what is the disease spectrum? That's what matters. I think Dr. Aditi, please continue.
So at this point, we gave the first pulse steroid dose of methylprednisolone, and the patient was transfused with 2 units of PRBC. After this initial management, we saw clinical improvement initially, as we can see in these lab trends. So since at this point, we have not ruled out yet the methotrexate toxicity, he was still on leucovorin, and we had started meropenem and levofloxacin to cover the sepsis picture that we saw. So he was growing aeromonas on blood culture, and he was also positive for pan-sensitive pseudomonas on urine culture. Procalcitonin at this point was raised to 96. So this was the treatment which was initiated along with the pulse steroid therapy which was being given. And in view of persisting azotemia, fluid overload, and respiratory distress, renal replacement therapy was also commenced. So after the dialysis sessions, there were further clinical improvement, but after a few days, there were a sudden drop in hemoglobin again, and the patient was now showing a picture of worsening ARDS. So then we got a chest X-ray done first. We can see bilateral chest infiltrates on the X-ray, and the CT also showed the same picture with bilateral alveolar infiltrates. So now our patient has a significant drop in hemoglobin, which bilateral chest infiltrates with a history of SLE. So we had to rule out a DAH in this case, for which we did a bronchoscopy, and alveolar hemorrhage was noticed on sequential BAL. We did it in the lingula region, which had the most dense shadows on chest CT, and the sequential sample showed a persistent hemorrhage in this case. So next, what we need to do was to send for a hemosiderin-laden macrophages, which has to be more than 20% to label it as diffuse alveolar hemorrhage, which in our case was negative, but that was probably because we sent the samples too soon, and it takes at least 48 to 72 hours for the macrophages to come into the circulation. So the other findings, the physical examination, radiographic analysis, the BAL analysis, the drop in hemoglobin, thrombocytopenia, and low C3 complement, hypocomplements, they all fit into the diagnosis for diffuse alveolar hemorrhage. And at this point, we had no confusion that the patient has DAH. So we had also ruled out other differentials which might be the cause for a alveolar hemorrhage. In this case, there was no growth on culture. The gene expert was negative, and CNCA, PNCA, as previously mentioned, were already negative. So this patient was labeled with DH and managed accordingly. The initial therapy in these cases includes systemic glucocorticoids, which this patient was receiving already. Another immunosuppressive agents which can be added depends on the case-to-case basis and also the severity of the organ involvement. Like in this case, the patient has initially presented with renal involvement and he was in severe organ dysfunction. So cyclophosphamide could have been the drug of choice, but then we had a septic picture going on. So we could not as yet start him on cyclophosphamide. Other drugs which could be given were mycophenolate, azathioprine, and plasma exchange is the definitive therapy in these cases. With IV immunoglobulins also. Although the combined therapy of plasmapheresis and IVIG has not shown to have any added benefits, but in our case, we did initiate him on plasma exchange sessions. 5 sessions were given in total. And after these sessions, he also received IV immunoglobulins because the septic picture was still continuing and there was refractory cytopenias. So we went forth with the IV IGs. So a total of 4 doses of methylpred 500 mg was given. Alternate day RRTs were continued. The patient was discharged on prednisolone 30 milligram and low dose mycophenolate with a plan to maybe later give cyclophosphamide or rituximab when the septic picture has cleared off. So at the time of discharge, his hemoglobin was 8.4, platelet has improved. TLC was still 15,000, creats and urea was still raised. Procal had now come down and blood culture showed no growth. This was the chest X-ray post-plasmapheresis. So to briefly put things into perspective, diffuse alveolar hemorrhage is a fatal respiratory complication of SLE. And since it does not have any specific symptoms that can be attributed to the condition, a high level of suspicion is key to diagnosis. Any sudden drop in blood hemoglobin, dyspnea, blood-stained sputum, if we see any diffuse infiltrates on chest X-ray, though we often suspect that it would be there, but in patients with DH, the radiographic images can be completely normal also. So that also has to be kept in mind. The single breath diffusion capacity for monoxides are increased because of the blood in the perialveolar region, which absorbs more oxygen. There is thrombocytopenia, hypocomplementemia. So any of these features, if we see, we need to do a prompt workup for DH. Incidence in SLE patients can range from as low as 0.6 to 5.4%. It's more common in young women with mean age being 27 years. And it can occur at any stage of the disease with the average mean being 35 months since the onset of the disease. An increased risk of DH has also been reported with patients who present with active renal disease, especially when manifesting as lupus nephritis. And affected patients can have recurrent episodes also. The risk factors which we need to keep in mind when we're looking for DH in these patients is if the SLE disease activity index is more than 10, that is if the patient has a severe disease, if there's serologically high titers of anti-dsDNA, if there's thrombocytopenia, low C3 levels, leukopenia, capillaritis, or immune complexes on biopsies, which have been seen, unfortunately, on a lot of autopsies also. So that shows how many cases go undiagnosed or are probably subclinical in presentation. So DH associated with SLE, it remains a diagnostic and therapeutic challenge with mortality being as high as 70 to 92%. So identifying any factors with the associated high mortality and taking immediate measures to diminish it, it becomes a priority. This was our happy patient when we discharged him. Unfortunately, we lost him a few months back. But just to conclude things, this case emphasizes the need for vigilant monitoring in SLE patients for rare but severe complications like DAH and the cause for multidisciplinary approach and timely interventions can have more happy outcomes in future maybe.
Thank you, Dr. Aditi. It was a nice presentation. First, I will ask Dr. Nitya to for few comments, because see, in routine we have discussed that whenever there are lung infiltrates in a patient of connective, we are always in confusion between disease flare or infections. And now that in this patient you already had a renal failure issue also going on now. So now the third thing comes up, that is your fluid overload as well, which can present like with shadows. So how do you take up, like when do you want to suspect DH? What are the clinical parameters and the lab parameters which you will notice and keep a close watch on to suspect this? Because suspicion is the first thing here.
Yeah. So I think practically, when we have a patient, it becomes very difficult because there'll be multiple factors involved. Like theoretically, we can say like hemoptysis and then drop in hemoglobin and all that. But that at that particular point, we are looking at different things like worsening of the disease activity itself. Then we are thinking whether it is some pneumonia or pneumonitis with ARDS kind of picture, or a fluid overload in this patient who anyways had an AKI. So we were thinking whether it's fluid overload. Bronchoscopy, yeah, definitely it'll help us with the diagnosis work. Sometimes practically, patient will not be on ventilator, patient will be on NIV. Putting them through bronchoscopy, we are worried that he might have to go on the ventilator, and already being immunocompromised, again, being on the ventilator might worsen the outcome. So these are the practical difficulties that we face. But yeah, once once he was not improving with the initial diagnosis, and then the bronchoscopy was done, and then the diffuse alveolar hemorrhage was detected, then definitive management was done, and then I think some positive response was seen in this patient. But again, we will be worried about infection being there. So there is a component of sepsis, secondary infection that the patient had developed. So again, the treatment also, like pulse dose steroid, will be worrying again whether the sepsis will worsen. And then plasma exchange being the definitive treatment, there might be instability that we see when we are giving the plasma exchange. So I think practically when we're seeing the patient, it becomes very difficult, and multidisciplinary approach, like we mentioned in any of these patients, including everybody like rheumatologist, pulmonologist, radiologist, everybody will help us with the management of the patient. Because in ICU, first thing we think about is infection. That is something that we are always worried about.
I will involve Dr. Rajesh Shetty sir in this. Sir, any cues on the ultrasound where I can differentiate between the fluid overload and the alveolar filling due to DH? Anything, sir? Can you throw some light on where I can suspect, just to begin with?
Yes, as Aditi had put in that slide, if any of those signs are there, there is a drop in hemoglobin, patient has got hemoptysis, and there is a history of some lung disease before, and there is no cardiac disease. I would go with most likely it is not fluid overload, and your usual basic critical care assessment focus will also help you. They may have a distended IVC, or the LV might be distended. There may be increased B lines. They might help, but having said that, sometimes it might be difficult actually. But if somebody has got hemoptysis, I would have this, and associated with the drop in hemoglobin, I would have this as one of the differential diagnoses. If it is not there, patient has a cardiac disease, and there is echo finding of reduced ejection fraction or increased diastolic dysfunction, then probably, or a CKD with AKI on top with fluid overload, then I would think that it is a fluid overload. But yeah, sometimes it can be difficult, I suppose.
See, it would be very difficult.
Yes, sir.
It would be very surprising if the patient has fluid overload. Because a patient who comes with this sort of a respiratory status, you're not going to fill him up with fluids. And unlikely he's drunk a liter of fluid and then come to you, with the respiratory distress. Yes, but focus will very clearly tell you whether it is fluid overload or not. If there is no significant history of cardiac diseases, then if the LV is okay, EF is okay, IVC is not distended, then it is not fluid overload. And if there are dense opacities of the X-ray, as well as confirmed on the CT scan, there is preferably, if there is some hemoptysis, then that will clinch the diagnosis. And obviously, if the patient is intubated, then the diagnosis will be quite clear if the patient has a significant amount of blood in the endobronchial secretions or whatever you take it. So I think that would be the clincher, and the therapy would why it would be the same: steroid followed with plasmapheresis if the patient is not getting really dramatically better. The mortality does remain high. I've had a few patients in the last couple of months. One survived, one died. But I think oxidation can also be a problem in these patients. So again, this thing is that see if there is a lot of blood in the tracheal endotracheal tube, then I think it is good idea to do the installation of Mesna, because that dissolves the binding between the blood and the mucus and acts as a mucolytic agent. So that works quite well when you instill it in the lungs.
In the nebulized form, you are saying, sir. In the nebulized form.
Nebulizer, you can instill it directly when you are doing the bronchoscopy.
Sir, Dhruv sir, any take on like what should be the threshold for bronchoscopy? Because doing bronchoscopy itself is a big challenge in these kind of cases.
Manju,
Yes.
one thing is very clear. We all talk about pulmonologists. We talk in terms of nephrologists. I think what you need here is a good internist having a reasonable idea about rheumatology. If you see this patient and the person who had a hemoglobin of 10, and within 4 weeks, there is no loss to the GI, where the blood has gone. The classical triad of diffuse alveolar hemorrhage always has been described, and we discuss in internal medicine. And other ways is drop in hemoglobin, rising breathless new shadows, and worsening hypoxemia, which is all there. Therefore, critically, you need to think in terms, we all start looking at fancy gadgets. They are important, but they are supplement. Therefore, I have no issues. This patient had a classical example in terms of acute worsening of rheumatological condition, where you have two systems dominantly involving. To begin with, it is kidney, and along with it, there is a hematopoietic system. And third thing, which is added to, so you are having a pulmonary renal syndrome. Along with it, you are having a hematological involvement. Obviously, that takes you away from anti-GBM disease or any other things, because by and large, if you see it, there are very few conditions who can look at it. What was odd in this case, which I was looking, if I sum it up for you, is that in the urine, I was not finding the RBCs. Because if the nephronal urea is there, one would have looked at the dysmorphic hematuria. Unfortunately, urine continues to be neglected area of investigation. And that dysmorphic hematuria would itself said that this rheumatological thing is associated now with an acute glomerulonephritis, because most of this sort of a picture we tend to see with DPGN, which is a lupus type 4 of WHO classification. I hope, Yatish, I'm right. And that's what you will look at it. And along with it, when you start, it's a capillaritis, which is happening. It is not a bleed in the tracheobronchial tree. So what you are seeing is a capillaritis. And because of this capillaritis, it is the alveoli which are diffuse alveolar. And there are 7 or 8 conditions which you look at it. And all of them are autoimmune conditions which are coming up. And when you combine them with the if there is a nephronal hematuria or there is an RBC cast, then things become much, much clearer. Treatment perspective, fair enough, you need corticoids. Now, obviously, plasma exchange is taking much more bigger role along with the IVIG. The only thing we need to be careful is when we are doing a plasma exchange and you start doing an IVIG, both things cannot go. They can be sequential, but they cannot be separate. And corticoids, obviously, in this patient, again, we were finding a very high values of PCT. And therefore, we need to be careful about, but be careful about procalcitonin. Today, we know that in number of inflamed conditions, it can go falsely high. But nevertheless, we have rightly done it as a word of caution. So I have no issues. And the definitive gold standard continues to be fiber optic. But in this sick patients, it becomes difficult. And one of the easiest way, as you have shown, is differentials in looking in terms of that there is a blood, there is nothing of that sort. That's fair enough. But what is most important factor which comes up is the macrophage, which are laden with hemosiderin. That is what tells us the diagnosis as far as alveolar hemorrhage is concerned. Tracheobronchial tree hemorrhage is the one where the blood goes into it, which gets round, which we see is a massive hemoptysis. And in these cases, again, we see a lot of edema, which is coming like a fluid coming like a pulmonary edema. Hemoptysis is not a very big feature of alveolar hemorrhage. minimal hemoptysis you will see. That is where the challenge comes up. Bronchial tree, or sometimes there is a rupture of old tuberculosis, Rasmussen aneurysms, or other malformation, not otherwise. As far as the treatment is concerned, I think perfectly managed case. And I agree with Dr. Mehta that it's a very high mortality morbidity. Nearly 3/4 of them, they die. And because the majority of them have an associated associations with kidney. Kidney is what? It's nothing else but a tuft of blood vessels. So there is the alveolo-capillaritis. Similarly, you have a capillaritis. Depending upon it, you have a differentials of lupus nephritis in different forms. So that's how it is there. Alveolar hemorrhage, only thing is that the problem with us in the intensive care is we are only bothered about infection, which is rightly so. But we need to have a holistic approach in order to reach a diagnosis. A person who is a known rheumatological one, there can be an overlap syndrome. And then along with an overlap syndrome, you are going up there. And let it be very clear, present of URNP, if there is an anti-dsDNA, it's all part and parcel of SLE. And what Dr. Yatish was also saying, in a progression, you can also see the definitions of myositis. One of the, if you look at the classification of the myositis, whether it's a polymyositis or a dermatopolymyositis overlap, this can be a part and parcel of lupus also. So it's very fascinating rheumatology as a part of internal medicine. But I think we must not forget to take consultation besides some specialty from an internist who can actually provide a lot of perspective in the management of these cases.
Yes, sir. Thank you, sir. Just for the student's sake, a basic thing is in a tracheobronchial bleed, when we do sequential bronchoalveolar lavages, the subsequent lavages will get cleared up. And in an alveolar hemorrhage, be it capillaritis or bland, the sequential ball will be either more hemorrhagic or at least persistently hemorrhagic. And we for hemoglobin macrophages, but unfortunately in this patient it was negative. But again we went through the literature where it says that in the very initial phase, definitely, yeah, macrophage-laden hemosiderin-laden macrophages may not be very easily identifiable. That's how, but we'll have to take a holistic picture to this one. Dr. Yatish, can you pitch in a patient of some connective disease, whatever it is, with the DH? First choice, you want to go for a plasmapheresis or you want to stick to your steroids plus IVIG?
No, yeah, I mean, this situation where, let's say, pulmonary renal syndrome, where it's an antibody-mediated capillaritis, I mean, there is a lot of inflammation in the capillaries. So, usually we club IVIG will not usually be the preferred choice. It's more of a plasma exchange because there is a renal involvement along with pulse steroids. And in this treatment also, in this case also, I mean, there was, I mean, I would differ in the treatment eventually offered. So mainly because as everyone was agreeing that it's a high mortality condition. I mean, if you don't, even if you treat aggressively, the chances of losing the patients are high. And here, what I would have differently done was a cyclophosphamide, which we discussed in the previous case also. Probably a little early in initiation would be more effective on a longer term. I mean, that is one thing, the treatment wise. Plasma exchange, steroids, and cyclophosphamide being the standard for these kind of situations.
So his blood culture was growing organisms and whatever it is, procure was very high. Would you still?
Correct. No, that needs to be adequately treated. I mean, as I saw this, I mean, this case, sequentially. See, what happens, most of the times when we are dealing with autoimmune condition, it's the infection which triggers an autoimmune response. There will be infection. In fact, if you see, even in the question answer session, I think Dr. Pankaj has raised a question: why to blame every time the infection? Isn't it easily treated cause or the just blamed one? I mean, infection, definitely, yes. I mean, infection we need to treat, but infection always triggers an autoimmune condition that when it is very aggressive, parallelly, we need to treat that as aggressive as it demands. I mean, in this case, yes, MMF, mycophenolate, probably will not start working for acute conditions like this. Probably hitting hard with cyclophosphamide, even then we may lose the patient because mortality is still high. but at least we would have given little fair chances if the patient would have survived.
Thank you for that.
And
input.
one last question, I think I just want to take one question which has been in the forum. Dr. I think Subhash Wage has asked why it can't be an acute immunosuppression by methotrexate. Probably by this time he would have agreed. This question was put when we were discussing in the initial pancytopenia and all. I mean, later on the disease evolution has told us that it is beyond methotrexate toxicity. Methotrexate toxicity typically comes with a typical mucositis and pancytopenia, more stabler picture. Usually, most of the times we detect in early, and there will be a clear history of methotrexate either being taken daily or overdosing. I mean, with the normal doses, what this patient were taking weekly doses, we don't see a high amount of bone marrow suppression with methotrexate. Go ahead,
How
Dr.
common is the renal involvement in a methotrexate toxicity? That is also a question.
That's what. Overall picture, I think this question was put up when in the initial slides. So now it is more clearer. Yeah.
Yes, sir. I think that gives us the answer that plasma exchange is the answer in these kind of cases of diffuse alveolar hemorrhage. Mehta sir, any inputs, sir, regarding how to handle these cases?
No, steroids and plasma exchange would be the first therapy. Cyclophosphamide, I think one should wait till the infection comes under control, as Dr. Neurologist has already mentioned it. So cyclophosphamide you can wait for a while, but I think steroids and plasma exchange is what should be done.
Yes, sir. Dhruv sir, any inputs, sir?
Yeah, I think we have discussed adequate amount of it. The only thing I am simply again trying to say in internal medicine, message to everybody, sorry to in the critical care, is evaluation of patient on a holistic basis is important. Use what you call it as a technology as a supportive tool. And there you see it, and when you take it up, it makes life easier to make a diagnosis. So you make a clinical and then support from the lab and the investigations do it, because that makes things much easier, quicker, and faster. That's all I'm saying. Rest everything, I think Dr. Yatish has also pointed it out. Dr. Shetty also has pointed out. And plasma exchange has actually really made the difference in these conditions more than anything else.
Dr. Nitya, any final words about this case?
I think everything has been discussed, nothing else to say. Yeah.
Rajesh sir.
Cyclophosphamide, one thing, yeah, this Dr. Yatish, so you felt in the ICU it should have been given?
Yeah, Dr. Nitya, I think I was involved in this patient this patient had a prolonged course in the hospital. So initially, yes, infection was probably high on the cards. It was adequately treated. Later on, at the time of discharge, I was little not very agreeing because the infection was treated, his lungs were cleared and things were improving. He was better. But we all, as rheumatologists, know that these are going to come back. These patients are going to come back with again a recurrence of diffuse alveolar hemorrhage. So we have seen that happening even when we give cyclophosphamide, even when we are given rituximab. As all the senior colleagues agree that even with the best of the care, we do lose patients. So probably hitting hard when we know that it's diffuse alveolar hemorrhage, his complements were pretty low, pancytopenic picture. I would not be very happy to discharge without giving cyclophosphamide at least. Yeah.
Okay, thank you.
Rajesh sir, any final words on this case, sir?
Yes, I agree with Dr. Yatish. As Dr. Yatin said, I will start with steroid and plasma exchange, and I would give cyclophosphamide if the patient is an appropriate antibiotic and infection is under control and there is no response to treatment. Patient continues to have symptoms and signs related to diffuse alveolar hemorrhage. That will be the time I would consider cyclophosphamide. So yeah, cyclophosphamide will be one of my choices, but later once the infection is under control.
Thank you, sir.
Thank you.
Thank you. I think we are done with the case presentations. Are there any questions? Any more questions? I think there are two questions which Dr. Yatish has already answered. Yeah, there are no more questions. So just to Paresh ji?
Yes, sir.
Any questions from any of the
No, sir. Both the question has been answered by Yatish sir and all the panelists. So this is the final remark which we can give, sir. First of all, we are thankful to Yatin Mehta sir, Dhruv Chaudhary sir, and especially thanks to Manjunath sir, Rajesh Shetty sir, Yatish sir, and special thanks to Marina ma'am, Aditi ma'am, and Nitya ma'am for this wonderful session, because we have started for this year. So once again, we'll meet with these all the suggestion provided by Dhruv sir and Yatin sir, with the coordination with the Manjunath sir. So once again, we'll meet on the in the month of Feb on the third Friday. So over to you, sir, and we can close the session with your permissions.
Thank you. I think
But you will continue to do it. He will
Definitely.
continue to do it. Dr. Mehta sir, he will be the responsible now.
So thank you. It's a pleasure. I
Also,
think we should close the session. We had a good discussion about those not very common but difficult problems to solve in the intensive care unit. So as Dr. Dhruv has nicely covered that, I think clinical judgment should go first, followed with the assistance from the investigations rather than the other way around. I think that one should never forget.
Thank
So
you, Dr.
Dhruv, a final word and we close it, I think.
Naini sir, I think it's very interesting. We learned so much out of it. We are only talking with our experience. You people talk with the literature, the youngsters. I think it's a combination of two things which makes the difference. And we have burnt our fingers quite often in these things. So with the hindsight, we are talking about it, what we have seen. And Dr. Shetty, thank you so much. And also Dr. Nitya,
Thank you, everybody. Thank you.
Thank you.
Yatish. Thank you so much, each one of you.
Thank you to all.
Thank you very much.
Good night.
Good night, sir.
I'm coming to your city, but I will be transiting through the airport. Thank you.
Thank you.
Okay. Supporting, we can close the session.
Okay, sir. Just give me 1 second, sir.
Thank you, sir.